Thank you so much, everyone. So what we'll do is we'll go on to the next session. Ladies, it shows you what such a good first session that was, because we've got you all talking about it. So that's absolutely fantastic, even if Carlo does ask too many questions. So what we'd like to next talk about is the MDT. And it's about demystifying the MDTs. Now, we know that in breast cancer, as in all of the cancers, all new diagnoses go through an MDT. And what we'd like to do is a kind of mock-up of the MDT, but it's going to be much more conversational. People are going to talk not only about what they would say in the MDT, but talk about why as well, and a little bit of the things that they're thinking about when they give their opinion. And what we'll do is go through a patient presentation, and we're going to look at someone's pathology, someone's images, who've kindly given permission for discussion today. She's not here, but she was very generous to allow this to happen. And what we're going to do at the end of the MDT, we'll run through the actual process, and then we'll have it open for discussion, and the panel members will be able to talk about it. And your eyes are not deceiving you. Ellen and I have the same dress on from Marks and Spencer's. How'd we do it? But I think we're both medical oncologists, and I think...
That's a thing from Dallas.
Yeah. But I think it's because we got the same... Spots. Oncologists have all got spots. Yeah. So just to make it easy, so you know who is who. I know. Oh, I feel very honoured that I have the same outfit on as Ellen, actually. Really honoured. Okay, so I'll just go through my slides. So I'm just going to go through a little tap dance of what MDTs are, and then I'm going to introduce the real stars of the show. Okay, so the MDT meeting is required for the diagnosis of a new cancer. So we confirm the diagnosis, and then we create a treatment plan together as a group. And I've just realised I don't have my right glasses on, so I'm going to move a little bit closer. I have the same problem as you. Okay, so the meetings are usually held according to cancer type. So we have breast cancer MDTs, GI MDTs, lung MDTs. And that's because we're very specialised now. Previously, the same oncologist and radiologist would be attending several MDTs, but now it's so cancer-specific because the areas are so super specialised that it's not possible to do that. Okay, so there's a range of specialities that come to the multidisciplinary team meeting. So there will be the clinical teams, many of whom you would meet during this process. There'll be clinical nurse specialists, the surgeons, medical oncologists and clinical oncologists, and we'll do a breakdown of what the oncologists do in terms of their sphere of expertise later on. There'll also be cancer service teams, such as the pathologists and the radiologists. And you may not be aware, but in the MDT, these specialities are actually king. They actually provide all the information for the diagnosis. And they're probably the people you don't meet as much during your treatments. In the wider team, there will be MDT coordinators who gather all the information together for the specialist to work on. There'll also be cancer pathway tracking teams, making sure that everyone is getting their scans, their diagnosis and their treatments on time, as well as making sure that they have appointments to have that information conveyed to them. There'll also be research teams involved in the MDT to identify people for clinical trials. There'll be geneticists involved, as well as supportive care, and some MDTs may have palliative care input. And ideally, these meetings are held on a regular basis, often weekly, because of the volume of patients that we see. There's a core membership, so to have an MDT that's functional, you have to have a minimum of a radiologist, pathologist, oncologist, surgeon, breast CNS. They're sort of core membership. You cannot hold an MDT without them. And within those MDTs, we jointly agree most of the time what's going to happen next. Okay, so it's considered, why bother with this? Because it's actually extremely time-intensive and very costly for the NHS to have these MDTs, because all of those people that I've just mentioned have to be available at the same time every week to do this process. So it costs tens of thousands for each MDT. And the reason why you do it is because it's good practice. It's open, transparent, you present all the medical information, you have scrutiny from your peers and a discussion of what would be next best treatment. And so what you're looking for is this evidence-based? Are we following protocols? And is this right for the patient that we're discussing? It's mandated for all new cancers in the UK and for all people who have relapse or recurrence of their disease or present de novo. They must be discussed in some kind of MDT. And we have very good guidelines as well and protocols to help us through this process. We have the NICE Early and Advanced Breast Cancer Guidelines. We have our own medical oncology groups, UK BCG. There's international guidelines, the American Society of Clinical Oncology, the European Society of Medical Oncology. Sorry, this is all oncology. There are surgical, there's ABS, and there's ASTRO and ESTRO, which are all the clinical oncology and surgical equivalents. Sorry, to skew it all to medical oncology. Thank you so much. And so it's also, with all of these guidelines and protocols, it's not in isolation of the person we're talking about. So it's really important to have someone in the room who knows the patient, who knows what's happening to them at this time, how fit they are, and what their wishes would be in this situation. And that's put into the plan as well. And increasingly, because of the complexity of the treatments that we now give, there are other MDTs which are specialised in particular areas. So for spinal cord compression or brain metastases, there are now separate MDTs in which you will have neuroradiologists, neurosurgeons and neuro-oncologists who specialise in treating those areas all at the meeting. And they wouldn't sit in the primary diagnostic meeting. Okay, so the MDT process. So what would happen is that for all patients who present through screening and are referred to a treating centre, as well as people who present through the symptomatic one-stop service, as well as people who have come through A&E or present as emergency presentations, they would all be listed on a weekly meeting. The MDT coordinator would gather this information, including the patient notes or electronic details, the images, any pathology taken. This list is then circulated to all the specialities, and everyone prepares for this meeting so they know that they can present their speciality details for everyone to discuss. The MDT on the day, now this is very variable. Some MDTs may be 1 to 2 hours long and can discuss 20 to 30 patients. Some MDTs may be regional MDTs where they may be discussing 50 to 100 patients, and it may be all day long. So they will vary area to area. The outcomes are all recorded, usually electronically now, and then they'll be shared to all the participants of the MDT, and then it'll be the pathway would be then to see the patient whose details have been discussed, so they have the information too. So the MDT outcomes are always recorded. The degree, the level, and we'll talk about this, how much is recorded can vary from MDT to MDT. Sometimes it's very detailed, sometimes it's guidance as to next steps. Okay, so forgive the cartoons, but I thought this would add an element of fun. I will just add, sadly, for the oncologist, all I could find was really nasty pictures about what bad things we do. So I'm so sorry. I've already apologised to Ellen and Jill. So I'm going to actually go around the MDT and ask people to introduce themselves. So we're going to start off with Mathew, probably the first person that most breast cancer patients would have met.
So I'm Rowland. I'm a breast surgeon, and I actually sit on multiple different MDTs. So I will sit on a breast screening MDT for people that obviously are well and haven't yet been diagnosed, what we call our main MDT, which is the predominant place where most people's cancer surgery and post-operative results are discussed. But I also sit on a secondary MDT, purely managing patients with secondary breast cancer, but advocating the role of surgery. And occasionally for breast sarcomas, I will sit on a sarcoma MDT.
I'm Sheetal Sharma. I'm a breast radiologist here in Liverpool, work with Matt. And similarly, I participate in the breast screening MDT as well as our main MDT, which is all of our non-screening patients, at least at the start of their journey. So you'll have met colleagues of mine around the country. I'm sure most of you, when you were diagnosed, we tend to see you for your imaging, do your scans and your biopsies, and then any further imaging, depending on your pathway.
So I'm Ellen Copson, a medical oncologist. So I take part in our weekly symptomatic breast MDT, which starts at 8 o'clock on a Wednesday. I've done my hour by Zoom from the hotel room this morning. It actually goes on for about 2 to 3 hours, and we go through about 60 to 70 patients in that time. There is an additional MDT on a Monday looking purely at screening and imaging. I'm not involved in that one. We don't actually have a separate MDT for secondary breast cancer, but what we do is the medical oncologists have a meeting every week where we discuss our patients with secondary breast cancer. So that's sort of how we define treatments beyond first line. First line treatments are still determined at the time of diagnosis in the main MDT. And in addition, there's separate MDTs that our patients may be discussed at. There's a SABR MDT, there's a neuro-oncology MDT, so if there are particular issues, we will refer them to those specialist MDTs.
Hi, Donna Murray, breast care nurse until very recently. Like Matt and Sheetal and Jill, attend the breast MDT for primary, and also have input in the secondary MDT if it's a patient that I know that I need to be there to represent on your behalf, because obviously you're not in the MDT. So as a breast care nurse, I'm there as you, really, representing your wishes and who you are and what you're about, and we'll talk further about what we do after the MDT.
And I'm Jill Bishop. I'm a clinical oncologist. I work in the Liverpool MDT with Matt, Sheetal and Donna. And our MDT is on a Friday morning, starting at 8, usually goes on till 10:30, 11. 50, 60, 70 patients. And I'm also a member of a metastatic MDT like Matt, where we discuss patients with secondary breast cancer, and then I'm acting as both a radiation oncologist and a systemic oncologist. So just so you know, clinical oncologists are trained to use both radiotherapy and systemic treatments, but some of us are more radiation oncologists and do very little systemic treatment, and some of us are like me who do both. So if you see a clinical oncologist, it may be purely for your radiation treatment and not necessarily for your systemic treatment. It depends how different places are organised in different ways.
Thank you so much. And that's our dream team that we're going to be working with now. Okay, so we're going to talk through one case in detail, because I think it gives us a chance to just talk about the nuances of what the specialities do, and gives you a chance, hopefully, to see things that you may have not seen before. So this particular lady initially presented in 2018. She went to MDT, her details went to MDT 3 times, and we're going to talk about when her details were discussed in 2018 and then in 2020. And that just gives you an idea of some of the things that we did. So as part of the case presentation, it's not like acting, but I'm kind of going to ask you to do what you would do normally in your MDT, if that's okay.
So I'm going to start off just to emphasise I may be the consultant and therefore I may be responsible for someone's care, but often a whole array of other people may have seen this person first of all. So nurse practitioners, registrars, breast physicians, and again, this is part of what we do at an MDT, that I have to read those letters, information, and put that together. And obviously in an MDT, it's often one of the few occasions now where we'll use very clinical or scientific phrases and vocabulary. In my clinical setting and in letters to patients, I try and make it much more accessible for everyone to understand. So if I was presenting this lady at MDT, in essence, I'm going to present this patient. I have a 38-year-old lady. She presented with a lump in her right breast that's been present for a few weeks, but no other concerning symptoms or issues. She's otherwise fit and well. She does not have any children at present and would not consider her family complete. Family history of note is that her mother has also experienced breast cancer in her 40s, but is now treated and well. On examination, we found a right breast lump, but no concerning findings in the left breast or the axillary lymph nodes. And therefore, this is to discuss her triple assessment and biopsies. By triple assessment, I mean that we're adding a combination of clinical, meaning what I have found by examining and talking to someone, with the radiology, so the images, and then any biopsy or tissue samples. And as an MDT, we're looking for something called concordance, which is that these all add up to saying the same thing, either that it's benign and we can reassure and discharge, or that it's cancer and then how best we manage it. And if there's discordance, so things don't match up, we decide whether we need more clinical information, more scans and radiology information, or whether we need more sampling, so more tissue or biopsies. So I'm asking, this is the clinical bit, can we put the other two bits together to make a picture that fits?
Sheetal.
So she came to see us, and you can see, I'm sure pretty much everyone, maybe bar Carlo, in this room has had a mammogram. So on the top image, so you all know that we take...
I don't know if you want to use the laser pointer. It's the white
I will try, hang on.
Yeah.
So we take two pictures of each breast, so that's the right breast and that is the left breast, and it was the right that she came with that we were interested in. And she's got an abnormality here where the background of the breast on a mammogram is darker generally, so fat on a mammogram looks black, and then tissue, so muscles, for example, these are the muscles that we all have here that just go up towards your armpit, and they look, oops, sorry, that was me, they look white, and we're looking generally for more white things, and here, which very helpfully has an X on it, is where we've seen an abnormality on that right breast. So then we've gone on to do an ultrasound scan, which is just above my head, and this is the area that looks concerning to me. It has what we would call irregular margins, so it's not like a nice smooth lump. It looks a little bit less well-defined than that, and that fits together with the fact that the surgical team have said to us, we found a lump in there, it doesn't feel definitively benign. So we found something on the mammogram, something that matches with that on the ultrasound, and then we've gone ahead and done an ultrasound-guided biopsy, which a lot of you, I'm sure, will have been through. And then she also, I don't know this patient personally, but she also went on to have an MRI scan, and there's lots of different reasons, thank you, sorry. Oh yeah. There's lots of different reasons that we do MRIs depending on the individual patient, but on the MRI scan, when we give contrast, it helps things light up. And this is the cancer here in that right breast, and this is 2 or 3 lymph glands in the right armpit, but this is the one that looks really concerning. It's enlarged and also lights up with the contrast. So we're dealing with a cancer in the right breast with at least one on this image, but I think there were more than one axillary lymph node that looks involved. So she will have had biopsies from both the breast lump and from the armpit to get a better picture of what's going on. And exactly as Matt says, we're trying to correlate what the surgeon or the person examining the patient has thought, along with what we think on the imaging, along with what the biopsy results show us. And we want all those things to be concordant, and that's part of what we discuss in the MDT.
Great. Thank you so much, thanks. So we're next going to go on to the biopsies. Now, you would have all had biopsies, and I'm just going to quickly go through the process. So these are core biopsies. These are the spring-loaded needles that you would have had. Take pieces of tumour from the breast or the armpit or elsewhere, and the little cores of tissue here are put into formalin. They have to be fixed and usually have to have 24, 48 hours to fix the tissues, and this sort of freezes the tissues and stops them deteriorating. Otherwise, you'd lose a receptor status and the integrity of the tissue if you didn't do that. So after it's been fixed in the formalin, it's transported to the pathology lab, and this may be another hospital, and then it's embedded into wax blocks, and then when it's put into wax blocks, it's cut in very fine slices, like 0.5 millimeter slices, sometimes 3 millimeter slices, and then it's put onto slides, and then it's stained. So these tissues undergo various staining tests to look at the architecture of the tumour and also to look for estrogen, progesterone, HER2 and other receptors. So as you can see, if you're doing all of these processes and there's a set amount of time that the tissue has to be in formalin and in wax and then it has to be cut, it takes several days. So it can take 2 to 3 weeks to get a pathology result back, and that's what's happening in that time. Now, all these scans... Sorry, Mathew, go on.
I know, obviously, we're presenting this as 3 separate MDT discussions. Usually, we would probably split up some of the discussions in that I think most of you would have experienced an initial consultation back for your results after this discussion, that we've got imaging, clinical examination and biopsies that confirm cancer. And one of the things that I forgot to say, as we all get a little nervous sitting on a stage, is as part of my initial assessment, I would have warned someone that I was worried that they had cancer. And even though I did not have these biopsies, I would have at that stage been honest with someone that that's my worry and concern, but also linked them in with Donna or one of her colleagues, because we acknowledge that the anxiety waiting for results is huge, waiting for this outcome, and that even if you do not have these biopsy results, being linked in and having access to someone that can support is hugely helpful. Perhaps it's a surgeon thing that I remembered my bit, but not necessarily everybody else in the team. But I think Donna's input would be really useful.
Yeah, so at this point, I'd meet the patient with Matt, meet yourselves, give you a contact number, because as you will well know, the waiting is the worst. And I think it's good to have that point to go to, so you don't just feel like you're a number waiting to go onto a list. You're a real person, and at that point I would establish what your support network is. You know, have you got someone at home? And this lady that Marina is presenting has got a relatively new partner, and the rest of her family live abroad. So we're looking at some networking from the outset, really. But we would have had many calls before we get to the next appointment. And sometimes I will warn the patient that actually that appointment may well be cancelled, because don't set your heart on coming, a week on Friday. That may be cancelled because we're waiting for further biopsy results. But I think sometimes the patient doesn't ring. It's just knowing that they've got that number should they need to.
Great, thank you so much, and thank you for reminding me. Thank you, Matt. So we would have the tissue, the core biopsies on a slide, mounted on a slide, and further stains will be done. The first stain is something called H&E, and here you can see the cancer. This is a grade 3 invasive ductal cancer. And I'd like to thank our pathologist, Ash Naruka, for giving me this. He was very particular. It had to be grade 3 and grade 2, but I did tell him it didn't matter. No one would know in the room. But he was very precise. It had to be the right morphology. Okay, so we went on to do estrogen testing. So the tumour was estrogen, strongly positive, 8 out of 8. Progesterone, strongly positive, 8 out of 8. And it was HER2 negative. There's virtually no staining there at all. Now, if you have HER2 2+, it's equivocal testing, so it has to go for a further test, either a D-dish or a FISH test, which is much more detailed, so it may need to go to another hospital. Hence, you can see why sometimes results that we expected to have are not available, and we have to move the appointments back. If someone has a triple-negative breast cancer, we may ask for dual PD-L1 testing. So that means 2 further tests. Again, it may not be done locally. It may need to go to another hospital, hence a further delay to get those results back. But without all of those results in place together, it's very hard to confirm the breast diagnosis phenotype and the further treatment plan, because the different breast cancer subtypes are treated so differently now. Right, I'm going to ask Sheetal to come up here because it's so hard to look up. I'm so sorry.
No, it's fine, don't worry.
So, and you can use this.
Yes,
and I'll
perfect. So this lady had PET CT for staging. In our trust, we generally do CT rather than PET CT, but there are different variations with how protocols are developed. But she's had a PET CT, and it makes my job look really easy because they just light up. So everything you're supposed to look at lights up, but it's not always that simple. But in this case, she's got the breast cancer, which lights up on PET, as does her axillary node that we saw on the MRI as well. But unfortunately, she's also got something in the liver, which is lighting up. So this is the liver here, this large organ, and this smaller organ on the other side is the spleen. But she's got a large, well, I say large, this here is very suspicious for a metastasis. And this is the CT image without PET. So that you can see it very subtly here, but it's much harder to appreciate than it is when the uptake is seen from the PET CT. So as far as we could see on the scan, there was nothing else. So she has what we knew about already in the breast and the axilla, but now we know that she's got what looks like a liver metastasis as well. So I think she then went on to a biopsy, didn't she?
She also had an MRI, which is a...
Oh, yes, sorry. So, yeah, again, on MRI, those of you that have had an MRI know there's lots of different sequences, as we call them, so sort of individual scans that are done in different ways. And what this shows on one of the sequences is, again, there was just that one metastasis. So we didn't see anything else in the liver that worried us or anything else elsewhere in the upper abdomen that's included on that scan. So she's got the breast cancer, the axillary node, and then this solitary liver metastasis, which, as we've said there, the biopsy confirmed a metastasis.
Thank you very much. So what we haven't demonstrated is that all of these images, for example, an MRI liver would have hundreds of images, which the radiologist would have been through, taken a few samples of pictures, sort of shots, to show to the MDT to confirm this is what I think is going on, and then we all agree that this is a case. And often there's another radiologist in the meeting, or there may be often two oncologists, so it allows a little bit of discussion if we're not completely agreed on a diagnosis or if it's an unusual presentation. Okay, so as I already said, this lady actually had a liver biopsy. We wouldn't always do a biopsy because if the pattern of spread fits, then a liver biopsy isn't always required. But in this particular situation, there was an MDT recommendation that she did have a liver biopsy, and that was concordant, using the term that Matt used earlier. It showed the same tumour as was seen in the breast biopsies. Okay, so I'll just jump to this one here, sorry. So we took the results of the staging scans, biopsies, including the liver biopsy, and went back to MDT, and we rediscussed it as a group. So it was confirmed a stage 4 breast cancer with a single liver lesion, what we'd call oligometastatic disease, and it was estrogen positive, HER2 negative. I'm now going to go over to Donna because Donna knows the patient. Now, Donna, what are your thoughts when you're seeing that at MDT?
So obviously the patient will have been seen by Matt with the results of the MRI and would have been asked to go for a liver biopsy. So she will have been prepped really for be expecting these results, potential outcomes of the MDT, what the MDT means and what we're likely to be discussing with her, and also what her thoughts and wishes are and what she thinks. Initially, there may have been discussions around fertility preservation, I need surgery, I need chemotherapy tomorrow, all of that, why is everything taking so long? Why are you not just cracking on with, give me some surgery or give me some chemotherapy, or, I want kids in the future, so what are you going to do about me fertility preservation? So we'll have had all of them conversations so that I can then be the patient's voice at the MDT to say, actually, Matt, she doesn't want to have such a thing, or she's discussed that she wants bilateral mastectomies. She has got a mum with a family history of breast cancer. Is that feasible? If that, what do you want me to take back to the patient? All them type of things, so that we can prep you as much as possible for the potential decisions and to voice your concerns and to voice your wishes, really, and what it is that you want. And just to make sure that everything's going to make sense to you at that point.
Great, thank you. So we opted for systemic therapy, so I'm going to hand over to Ellen and Jill. What are your thoughts regarding, from an oncological point of view, your decisions at MDT?
So I would be confirming with the MDT that I have understood the situation, that this is a patient with oligometastatic disease and that it's ER positive and HER2 negative. And on that basis, I would be recommending drug treatment first. And this is an area of breast cancer care that's changed massively since I became a consultant back in 2009. At that point, I'd have probably automatically been recommending chemotherapy as first-line treatment because we've got disease in the breast, under the arm and in the liver as well. But that's completely changed with ER-positive, HER2-negative breast cancer because for the last 7-8 years or so, we have had a targeted therapy called cyclin-dependent kinase inhibitors, which is a tablet treatment taken alongside hormonal therapy. That is not only as good as chemotherapy, it's actually better in a lot of situations for patients with this type of secondary breast cancer. It has much less side effects than conventional chemotherapy. It's tablet form, so although it does certainly have side effects and needs monitoring, for most patients it's much less intrusive. So that would be in its gold standard now to recommend this as first-line treatment, except in very, very rare occasions when we might need to consider chemotherapy as an alternative. So that would be my recommendation. Particularly if the patient was older and had other health issues, I might be asking the MDT a bit more about that to make sure that this still sounds like the right approach. The other thing I'd be thinking of is, are there clinical trials that might be suitable for this patient to go into? Actually, we do have a trial available locally, an observational trial, which is using a novel blood test to identify and predict response to CDK inhibitors. So I'd be alerting our research nurses to the fact that this patient might be suitable for this. And with my genomic interests hat in, I'd have also clocked that this is a younger patient and therefore with this type of secondary breast cancer is eligible for BRCA testing these days, so I'd be initiating that as well. But perhaps one of the most important things I would also want to do, because it's most likely, unless Jill contradicts me, that the patient is going to be coming to see a medical oncologist first, I want to be really clear about what the patient knows at this point. Is it going to be me breaking the news that this is metastatic disease? And is there the opportunity to have one of the breast cancer nurse team with me when we have that conversation so that the patient is supported?
So I'd agree with all of that. I think one of the questions we're often asked is, why can't I have chemotherapy? Chemotherapy works quicker, it works better, and we've now got good evidence that by using this group of drugs called the CDK inhibitors, that we get responses that are as good, that are durable. You're talking about responses that can be lasting 2-3 years. I've got patients who've been on this drug for 7 or 8 years. And without the toxicity of chemotherapy, so no hair loss, no limited nausea. You might have some problems with low blood count, but not to the same extent as chemotherapy. You certainly don't seem to get admissions to hospital with toxicities in the way that you could and still do with chemotherapy. The other thing I'd be saying on top of those things is our patients understandably get very worried about, well, what if it's not working, it's just a tablet. So it's the reassurance about how we're going to monitor, how often they'll be seen, who will be seeing them. So it might be Donna, but it may also be we're lucky enough to have metastatic specialist CNSs, so plugging into the metastatic CNS team and so on to make sure that patients are reassured that they're going to be seen regularly, supportive, a response assessment will be made. As well as toxicity assessments and so on. The other thing, just because I'm a clinical oncologist, I have to think about radiation. At this point, I'm often asked, well, why can't you just take the lump out? And I'll not steal Matt's thunder. But from my point of view, I wouldn't be thinking about radiation at this point because there is limited evidence that it's got any role at this point.
And what I might do in the interest of time, because we've got the little red marker there, and we're well over. So what I'm going to do is just go through the history and then allow it for discussion so we can make some progress on that. So we did, in that MDT, discuss what we call primary debulking. And there is, at that time, in 2019, 2018, there was evidence that if you remove the breast cancer, treat the primary, there may be benefits in living longer with metastatic disease. Now, that was not clear-cut. At that time, there were some initial reports, but that's now not certain. And so this is not standard of care, but it gives us an example how things change over time. And each time we work with the best evidence that's available. So we did discuss, can she have her liver lesion ablated? She couldn't have SABR. We still had the synchronous restrictions on having high-dose radiotherapy. Would she benefit from surgery to the breast and armpit? And again, we discussed it, but we said, okay, let's hold. Let's just get started on the first bit, and we'll talk about it again. Now, it's actually 18 months later. She had a rapid metabolic response. She did very well, tolerated all the therapy, and there was a good response at all sites. So that, as her medical oncologist, I referred back to our MDT to talk about things again, because we had discussed liver ablation and surgery. So we went back to the MDT, our same crowd, our lovely panel here, and I'm just going to ask Sheetal to just go through some of the images.
Yeah, I'll stand up again. Probably easier to show you this way. So the previous one, which you've just seen, is along the bottom, but over the top now we can see a massive improvement. So the uptake in the breast and the uptake in the armpit have pretty much gone completely, and in the liver, just a massive improvement. So there is very, very mild uptake, but it's always not. These are the scans we like to see because it's a really clear indication that everything has responded to treatment and everything looks like it's getting better. So they're the nice reports to write because it's good news for the patient at this point. And that's a nice one to take back to MDT and say that everything looks better. Sorry.
Really hard ones that I can't do.
Oh yeah, this is the liver. Well, I mean, we'll keep it simple. So this is probably the easiest one to see it on, or these two in the middle. So this was the largish metastasis in the liver in 2019. And now I don't think you need to be a radiologist to see that it's smaller. If you're just comparing the two images together, this has just got smaller. So again, that fits with what the PET-CT showed us. So these are all, we do lots of different sequences, as Marina was saying. So lots of scans for us to look at when we're doing a report, but for MDT purposes, we tend to just show representative images so we can clearly show to the people who aren't radiologists that things look better or worse when they do look worse, but fortunately in this case, not worse.
Thank you so much, Sheetal. So, and importantly, for the next step, there was no evidence of new sites of disease and no spread within the liver. So we agreed at our second MDT to proceed to breast surgery, axillary clearance. I have to say things would be different today if we were looking at it. This is not something we would necessarily do. And also ablation to the liver. And this lady also received radiotherapy to the breast and axillary lymph nodes. And this is definitely not something we would do today.
I think when we're planning surgical treatments, our goal is now we're looking at trying to avoid symptoms and problems, and we're trying to preserve quality of life. And also, we often have to have people have a break from certain treatments to safely do surgery. So that's where we'll discuss that and try and balance that in an MDT. And as Marina says, we probably would go for breast-conserving surgery where possible, because it's going to be less invasive, give people a better quality of life, and we would probably avoid the axillary surgery unless there was continuing disease there. But this has changed in quite a short space of time. And the discussion that we had, actually, this lady probably wanted to preserve her body image and feeling of femininity because it was still very important to her about pursuing relationships. So I think in this day and age, things change quickly. We'd probably done something slightly different, but the goals will have been the same there. Preserve quality of life where possible and try and prevent problems.
And Jill, sorry.
So one of the things you might ask, well, why didn't you do this at the start? And the reason is we've got reasonable evidence that if we delay systemic treatments, that we actually get to go to then to SABRE or RFA or whatever, we actually get worse outcomes, which is why we start with systemic treatments, and then if there's good response, go on to appropriate local ablative therapy, LAT, with evidence that if we can completely ablate metastatic disease, oligometastatic disease, that we get better outcomes. The reason I personally wouldn't give radiotherapy is, particularly after an axillary clearance, there'd be significant risk of lymphedema, worsening of quality of life, and it potentially restricts what I could do in the future.
Yeah, and I think our MDT would not give radiotherapy now because there's been data published since then that it doesn't give additional benefit. So I think that's the thing about working all together and keeping up to date is the data changes. And if you're not going to improve quality of life or prolong survival, you shouldn't do it because more is not better. You need to sequence it, and so it's appropriate each time. So afterwards, several years later, actually, further RFA to the liver was required due to a lesion just adjacent to where the previous RFA had been done. And then, unfortunately, a year after that, multiple lesions appeared, and we had a change of systemic therapy completely. Now, we don't, when there's treatment changes now, there's an oncology note round in which we have several oncologists sitting, which we discuss further treatments, but it doesn't go back to the main MDT because unless there are specific requirements for radiotherapy, MAT's involvement isn't so important, we think. There may be in the future, but at the moment we don't think so. Okay, so the take-homes is that MDT is important for diagnosis and planning of treatment. We changed treatment as we went along over the years, and we all agreed as a group on the recommendations. They're the cornerstone of what we do, and I think it's a gold standard globally now for everyone to discuss treatments, and no one's treated in isolation. And it's really the collective discussion between specialities that I think allows a wider discussion of all the different things that we can do. Now, there's increasing, as our treatment algorithms become more and more complex, we're talking more as a community, and we have, fortunately, more oncologists, more radiologists, more surgeons within the specialities to allow this discussion. Okay, so what I'd like to do is just close it there. Thank you very much. We've run over terribly, but thank you. And thank you to the wonderful panel. Now, we probably have about 3 minutes to give questions. I'm so sorry about the timing, but I think it was worth just hearing what the panel thought at each point. Any questions at all? Oh, okay, so we have some questions on Slido. Okay, so I find it worrying that a CNS is representing me at MDT. At primary, I barely had any interaction with them, and for secondary, I only see them after the clinic, so post-MDT. Should we not be asked to make a patient statement to present our views at MDT? So what are your thoughts? Donna, can I start with you?
Yeah, absolutely. So apologies, that's your experience. I hope that's one of few. And certainly if you're not feeling heard in an MDT, or you're not getting answers to questions that you specifically asked for me or the consultant to discuss at the MDT, then that's something that you can really escalate. By all means, write a statement. I'm quite gobby in MDT. So I'm not bothered if I get shouted at on your behalf. I'll quite happily trundle on, challenge oncologists, challenge surgeons on your behalf. That doesn't faze me. It may faze other people, obviously, but certainly it was well within your rights because this is affecting your life. You know, and I always say when anybody's having investigations or waiting for results, you know, these are your results. This is your information. This belongs to you. Yeah. And how that's interpreted by you and is delivered by you is really important. So just be gobby.
Yeah, and can I just add something to this? In MDT, we took half an hour to talk one person. I'm afraid because there's often 60 patients on the list, the discussions, it'll be very quick, very thorough, very technical, And what we do is guidance. What happens in MDT is what should be technically done on the evidence base, but that can be modified in the clinic because it's guidance. It's not, this is what has to be done. This is what happens at MDT is what's correct according to current evidence and protocol. What is the correct thing to do? But there's always a line to say that when someone discusses it with you in the clinic, in the surgical clinic, in the oncology clinic, it may totally change. And that isn't taken away from you or your autonomy in any way, I think, if that's okay. I've just got one more question I'd just like to ask. So we all know that the news you're about to receive is likely to be bad when you walk into the room and you see someone other than the oncologist. Can we change this? And I don't know how we do this. I think this is a real problem, but my presence, my name badge, it's got my title on it, having me involved, as soon as the people know they have an appointment with me, we try to keep it sequential, but that is an issue I think we all face. I don't know if anyone wants to comment. So Donna or Matt.
I think the warning shot at the beginning with Matt is massively important, and maintaining that relationship and discussing the possible scenarios of, you know, what may happen along the way and who you may be seeing, and, you know, and just trying to get that continuity, really. And it is difficult sometimes, and we have cocked up, for want of a better description, sometimes where a patient's got an oncology appointment and she hasn't even had the results yet. So we do have human error, and as much as we can, we try to avoid things like that happening. But I think the initial meet-up is important.
And people do, you know, I think we all shout at each other saying, whose fault was that? Because it's not how it should happen, and we try very hard that it doesn't happen.
Yeah. And those sort of errors sometimes happen because our admin team have been super efficient and they know we need to get the patient in, and messages get in the wrong order. I think the other thing is that particularly with secondary breast cancer, the treatment pathways for triple negative versus HER2 positive versus ER positive, HER2 negative are totally different. So we really do try and wait until we've got that key information before we see the patient in an oncology clinic, because otherwise you end up describing one lot of chemotherapy versus one lot of, you know, hormone tablets versus a totally different pathway with immunotherapy. Which is highly confusing for everybody concerned, and it's so much clearer if you can say right at the beginning, this is what we're dealing with, this is the best way to deal with it. But absolutely, we appreciate that that can mean delaying appointments, and that's, you know, extremely anxiety provoking for people. So it's a difficult situation, particularly when sometimes it can take a few weeks to get the HER2 status back.
And I think sometimes there's just no ideal way to do this. We're trying to pick the best of often really challenging circumstances. So yes, some people will walk into a room and they'll spot there's a specialist nurse with me, and that will be the key for them, that they know, oh, now I know what is coming. But why are we doing that? Well, we're doing it because we didn't like the way where I tell you that it's cancer and then go, oh, I'm now going to bring someone different in who, when you're trying to process that, it's a new face, it's a new name, sorry, what is their role? Or what I feel often is even worse, where, okay, I've finished with you now, so-and-so's going to see you, but in a separate room, and we want you and whoever's come with you to get up and go into a separate room. So I think we're all human. Sometimes we don't always do it in the most tactful or the most sensitive way, but often we're just trying to negotiate things like the clinic rooms don't really work, the number of people we've got coming to clinic doesn't really work. And so, yes, I'm sorry, sometimes it won't be an experience that people feel could have been handled in the best way. We are often trying our best, you know, I think sometimes all we can say is we do our best.
Thank you. I'm just going to take one more question from the floor. So just that'll be the last question. I'm so sorry.
Thank you for showing this, because it does help knowing that my doctors went through the same way that you all did. So thank you for that. My question is, in terms of being a strong estrogen positive, like you saw 8 out of 8, is there a correlation between that and the treatment?
Yes. So I'm going to... Jill, would you want to take that?
So I'm assuming you mean if you are ER8 of 8, what's your likelihood of responding to that treatment?
Yeah.
Is that, yeah. So that's a really good question, because there should be a correlation, but we actually know from other data that even if you're only weakly ER positive, that you may still have responses to treatment. So particularly in patients where they are reasonably well without lots of symptoms from their cancer, we might actually try, even in somebody who's relatively weakly ER positive, a hormone treatment in order to avoid toxicities. And that's a discussion to have with the patient about what's important to them, what side effects are important to them, likelihood of response and so on. And it's quite important then for us to discuss options with you, because this isn't just about what we can give you our advice as medics on the basis of the evidence, but it's your body, your treatment, you get an input into this.
Great, thank you. I'm now going to close the session. Thank you so much, panel. Thank you.